Okay. Good afternoon, Bhattacharya sir, and good afternoon all. Sir, am I audible?
Yes, yes, good afternoon.
Okay, sir. Thank you. Welcome to this platform, sir. There is some issue in my video. Okay. So let us start this program. Good afternoon, everyone. It is my great pleasure to introduce Dr. Devadatta Bhattacharya sir, who is joining us today as a resource person for this faculty development program. Dr. Bhattacharya is a distinguished scientist currently serving as Scientist E at the ICMR Regional Medical Research Center, Bhubaneswar. He has made significant contribution to the fields of clinical microbiology, virology, molecular epidemiology, and public health. With over 2 decades of experience in infectious disease and zoonotic disease, Dr. Bhattacharya has led various research projects, published extensively, and guided numerous PhD students, postdoctoral fellows, and MD scholars. He has published articles of overall around 111 with total impact factor 512.64 and with an average of 4.61, citation index 1734, H index 22, I10 index 49, and with policy brief, one policy brief, 6 book chapters, 4 magazine articles, and 7 poster presented at international conferences. His remarkable career has earned his recognition both nationally and internationally. He has been awarded the prestigious Bill and Melinda Gates Award 2024 presented at the International Society of Infectious Disease Congress in Cape Town, South Africa. And also he has visited number of countries as a invited speaker and delegates. In addition to his research achievement, Dr. Bhattacharya holds significant academic roles, including being an associate professor at the Academy of Scientific and Innovative Research and a member of various important committees for public health and zoonotic disease management. Today, Dr. Bhattacharya sir is going to present on the on his research work related to that is molecular disease diagnostic and novel technology for SARS-CoV-2 diagnosis. We are truly fortunate to have him with us today. His expertise and experience will be invaluable as we explore the latest advancement in microbiology, infectious disease, and public health. Please join me in welcoming Dr. Devadatta Bhattacharya sir to this faculty development program. Sir, over to you, sir.
Thank you, Dr. Kaur and Dr. Panda and the entire MITS, all the MITS member for inviting me for this faculty development program. And today I'll be presenting on a bit of molecular diagnostics, importance in molecular mechanism for diagnosis, as well as our the novel technologies of molecular diagnosis that we have used for COVID-19 during our COVID-19 pandemic. There are some innovative approaches that we have done, and which was given us a lot of accolades to us as well, our lab as well as the institute. So I'll just share my slide. Dr. Karp, could you just allow me to share, because I think you have restricted me from sharing the slide.
Okay, sir. Let me check. Sir, allow him for a moment. Yes, sir. Now it is visible, sir. Sir, it is visible, sir. Hello.
Is it in full slide? Is it in full slide mode?
No, sir. It is like in PPT mode, not in the full slide. Sir,
Could you just make me the co-host of this meeting? I think there is some problem with the sharing.
yes, sir. We are trying to do, sir. Yes. Just a minute, sir.
Dr. Subrat, can you hear me? Is it visible?
Yes, sir. It is visible, sir. Sir, try to check it is moving or not.
Could you please make me a co-host in this? Because I think there is some issues with your Google Meet, what
Sir,
you have shared.
today it is free to all. It is you are by default a co-host, sir.
Oh, I'm not a co-host.
Sir, can you share your slide to us? Can we can do that in So wait for the few minutes. We are doing that, sir. Sorry for the inconvenience, sir.
Sir, good afternoon. What is sir? Good afternoon. Sorry for the inconvenience. It's open, sir. Could you please?
No, actually, they have to make me a co-host here. Because
They
there is-
made, sir. Everyone is open to share the screen. Today we have made open for all.
So see, it is always writing something wrong when screen sharing. Try restarting your browser if the problem continues. I have shared my PPT with Dr. Kaur, Dr. Subrat. He can share.
Fine. Fine, sir. In minutes we are fixing it also. Please.
So is it visible to everyone?
Yes, sir. It's clear.
Okay. So you will be changing the slide for me, okay?
Right, sir.
Thank you. Thanks once again to the entire faculty of MITS Bhubaneswar. I was bit attached with MITS a few years back because my wife was working there as a faculty. So, till 2020, I think. Then, so I know many of the faculties there. So, and many of the students of MITS are working in my lab, as well as they had passed out and now they are working in a good place or placed somewhere good. So, and we get MSc dissertation students frequently every year from MITS. So, so we work very closely with MITS. I congratulate MITS inter faculty for this organizing this faculty development program. So I'll be presenting on this molecular diagnosis and the novel technologies that we used using these molecular technologies for the COVID-19 during COVID-19 pandemic. So coming to the history of disease diagnostics, as we all know, the why we use a disease diagnostics is important for better treatment outcome, the ability of a healthcare practitioner to effectively deliver the effective care or effective treatment depends upon the ability to accurately identify the cause of a patient's problem. That is to make the diagnosis. Without knowing that it is the fever, it is due to scrub typhus, or it is a JE, it is a dengue fever, it is a chikungunya induced fever. It is very difficult for the clinicians to make a treatment guideline. So for an effective diagnostic, for an effective healthcare treatment, we need a disease diagnostics. So over time, our understanding of the mechanistic basis of disease has increased, and further our ability to make more accurate and specific diagnosis has enhanced. Because earlier, scrub typhus was very limited. Knowledge of scrub typhus existed among even in the urban setting of Bhubaneswar. So lateral, when at RMRC or some AIMS Bhubaneswar, they started diagnosing scrub typhus. So the doctors, the clinicians here also understood the scrub typhus is also a frequent disease prevalent in this city. So as a differential diagnosis, they started investing scrub typhus too when there is a cases of unknown fever. Early healers, we all know, needed only to feel the patient's skin to diagnose fever, but with further understanding of different illnesses and their symptoms, doctors gained the ability to distinguish between yellow fever, scarlet fever, bubonic fever, and other types of infections. It was advent of modern microscopy and histopathology or cellular pathology in the 19th century. However, it enabled a tremendous leap forward in our understanding of the biology of the disease at cellular level. In the present time, we have n number of advanced diagnostic technologies like cell culture, additional antibiotic sensitivity testing, minimum inhibitory concentration tests, E-test, epsilon test, genetic information from molecular diagnostics, which provide a very concrete clinical evidence for the treatment to be made. So molecular diagnostics is the use of molecular biology techniques to expand scientific knowledge of natural history of disease, identify individuals who are at risk of acquiring any specific disease, like some genetic markers they use to predict that if they have a chance of getting a particular disease, diagnose infectious and other human diseases at molecular level. Next. Molecular disease impact, monitoring a disease more accurately allows for early treatment and better patient outcome. Determine most appropriate treatment means it reduces or eliminates unnecessary treatment, because if we know if it is a case of dengue, if we know it is a case of scrub typhus, if we know it is a case of JE, we know what is the treatment regime. So clinicians, based on the evidence, they use the treatment. So it cut down unnecessary use of other treatment or antibiotic use, reduces or eliminates inadequate treatment, and greater cost effectiveness. I will tell you next. Greater reduces, it brings down the cost of treatment, because as we know now most of the treatment cost is being borne by the government. So once a definitive diagnostic is done, the cost of treatment is also brought down. It reduces the patient's morbidity and mortality. Morbidity means the chances of getting illness, and mortality means death. Next. In 1998, the National Institute of Health Biomarkers Definitions Working Group defined a biomarker as a characteristic that is objectively measured and evaluated as an indicator of normal biological process, pathogenic process, or pharmacological response to a therapeutic interventions. Identification of novel molecular markers will facilitate the development of a useful molecular assays for detecting, diagnosing, and predicting disease outcomes. There are three keys of biomarkers employed for clinical decision making. That is diagnostic, that is a definitive diagnostic for treatment. Prognostic, when you use some predictive markers to see that treatment, how is the treatment going. Like for we do the HIV viral load testing for the ART treatment, means antiretroviral therapy treatment for the HIV patients. And predictive biomarkers like the cancer biomarkers, those are used to predict if there are chances of occurrence of a cancer. Next. Again, diagnostic biomarkers facilitate identification of cancer type or subtype. Prognostic biomarkers aid clinicians in determining the risk of relapse or disease progression after therapy, wherein patients with high risk are selected for aggressive screening or adjuvant therapy to prevent recurrence. Clinicians utilize predictive biomarkers to select one therapy over the others based on associations between biomarker results and likelihood of response to certain therapies. In practice, predictive biomarkers often identify the molecular targets of relevance to targeted anti-cancer drugs. Next. So as we all know, there with advanced molecular diagnostic techniques, there are n number of techniques presently available. The few commonly used techniques are polymerase chain reaction, real-time quantitative PCR or qualitative PCR, in situ hybridization, DNA chips or microarray, and Sanger sequencing and next-gen sequencing. Next. So coming to the PCR, I think we all know about a basic of PCR. Actually, it is nothing to make other than making a Xerox copy of a particular gene. So the specific markers are very small to look into a naked eye. So we make a multiple copies of that gene so that it is visible. And the essential, the basic principle of this PCR is amplification, the process of making copies of specific DNA or RNA sequence found in a sample. These are there are a number of different amplification techniques, but PCR, as I told you, is the most widely used and considered a workhorse in molecular diagnostics. There are different types of PCR. There are multiplex PCR, there are nested PCR, semi-nested PCR. So multiplex PCR, what we use in a single PCR, we use multiple gene detection, like for pathogenic Vibrio cholerae. When we do our diagnosis of cholera outbreak, we use a array of 5-6 genes in a single PCR. So in PCR, you can see those 5-6 genes are whichever those genes are present, they are amplified, and the n number of copies of those genes are made, which are then visualized in the gel electrophoresis. So this is a multiplex PCR. In nested PCR, what we use, it is basically used on hepatitis B detection, where we initially amplify a certain area or a certain area of a gene, and in nested PCR, what we use, we then amplify another region within that amplified region. So suppose initially we have amplified a 500 base pair region. So in the next step, we use that 500 base pair as a template, and we amplify around 250 or 300 base pair region within that 500 base pair. So it is much more precise and much more specific for diagnostic of mostly used in viruses, DNA viruses. Next. Real-time PCR, that I think most of you have come across some this real-time PCR after the COVID-19 pandemic. There are two types of PCR mostly use the Tachman chemistry, where we use a fluorescence resonance energy transfer, and the dye are when the amplification happens, dye is removed, and that is detected in the the fluorescence of the dye is detected by the specially made camera in the RT-PCR machines. It is developed in early 1990s. qPCR is widely used in both clinical and research setting for genotyping, gene expression, and pathogen detection. qPCR is extremely rapid and robust, which is beneficial for point-of-care application. It takes around 1 hour to 1.5 hours for diagnosis or detection. You have gone back again. So its high sensitivity and specificity make it gold standard for clinical gene detection with several US FDA approved kits. Now, since COVID-19 pandemic, we have got many indigenous kits also, which are approved by our CDESCO, which is the authorized agency for approving the diagnostic kits in our country. The number of simultaneous targets that can be detected is in hundreds rather than the thousands of microarray and NGS. These methods also requires primers and probes designed for the specific targets. Next. Coming to Sanger sequencing, it is a capillary sequencing where we are interested in a very small, in Sanger sequencing, we generally sequence a small region ranging from 200 to 1000 base pair. It is the most common technique where to detect drug resistance, SNP, single nucleotide polymorphism, or mutation detection. In this, the dye is coded in the PCR during PCR, and this ATGC are coded with a different color dyes which are detected in the camera of the sequencer machine. So here you can see these are the peaks. When there is a there is this kind of peak. When there is G, there is a green colored peak. When there is a T, there is red colored peak. So these peaks are here. You can see this is the rating G, G, C, G, C, A. So these are the nucleotides which are detected. Then we convert it into the amino acid. Then we look for the mutation. Here we have given an example where you can see there is a change with here you can see that in the position 83 you can see some these 5 are green. Then there is a this yellow line where there is a change of leucine to serine to isoleucine. So there is a this change of amino acid which is this was done to see the mutation in the quinoline resistant determining region. This quinoline resistant determining region is a region where the fluoroquinolones like ciprofloxacin, norfloxacin, ofloxacin binds to the DNA of this bacteria and kill them, and that DNA reproduction doesn't happen. So when there is a change in this amino acid sequence, the drug could not identify its sites of binding, and it becomes ineffective, and the drug and the bacteria become resistant to that particular bacteria. So this is one of the application of Sanger sequencing. Next. So the novel technologies, now I'll tell you what we use for COVID-19 diagnosis. Next. So basically we had during COVID-19, each of the kits that was available in the market detected some particular genes like ORF1, E gene, that is envelope gene, it is an envelope protein, S gene, that is spike gene, which is responsible for the binding of the virus, and most of the vaccine that Covaxin and all that is made with the spike gene, and the N gene, that is nucleoprotein gene of the human SARS-CoV-2. So these are the dyes which are used for the detection of these particular genes. So as we all know by this time that if CT values were mostly in RT-PCR, if CT values are less than 40, the test is valid, and if CT values is above 40, test is invalid. Next. So initially when COVID-19 pandemic happened, we have seen how healthcare providers, means who were mostly involved in collection of the samples from the infected patients, were severely affected, and we had very huge crunch of manpower for collection and or screening of these patients. So which tremendously affected the containment of the COVID-19 initially. So you can see several papers published in reputed journals where it shows risk of COVID-19 among frontline health workers, safety management of nasopharyngeal sample specimen collection, complication of national and oropharyngeal nasopharyngeal swabs collection, cerebrospinal fluid leak after nasal swab testing. So initially came across all this paper, and we at lab, we thought, let us come up with some technology where we can be of some relief to these healthcare workers. Next. So we effectively demonstrated how saliva can be used to diagnose COVID-19. So it was widely covered by Times of India. RMRC study on use of saliva COVID-19 test shows promise. So it was again published in Journal of Medical Virology with the impact factor of 20. Next, in the study, what we did. So as I told you, sampling from nasopharyngeal, anterior, nasal, and mid-turbid swabs are 3 of the 5 methods which were initially declared by WHO, followed by RNA extraction and quantitative RT-PCR as a gold standard for detection of SARS-CoV-2. The conventional nasopharyngeal swab testing always demanded highly trained personnel for sample collection, as issues in the is this crucial step often leads to false negative result, because if the collection is not proper, it may give a negative result and may lead to other clinical complications. Considering these factors, NPS is quite complicated to be robustly used in densely populated and economically developing countries. Throat swab, because economically developing countries, why I told that in economically developing countries, initially in India, we had again the limited manpower who could be engaged for the sample collection. The throat swab are also being used for detection of COVID-19, but sometimes it is considered as a less sensitive method compared to NPS. Moreover, these two commonly used methods of sample collection are invasive and very risky for healthcare workers who were recruited and exposed during collection of samples. Next. What we did in the study, we enrolled 74 suspected COVID-19 hospitalized patients from different COVID-19 care hospitals in Bhubaneswar. We got an institutional ethical approval and written informed consent from each of the participants. We told them why we are doing the study, and they gave them their written consent. Both NPS, because since NPS is a gold standard as defined by WHO, so we used NPS as our comparator for saliva. So we collected both NPS and saliva within 48 hours after onset of symptom. Saliva specimens were collected by the patient themselves in a sterile sputum container and transported as per standard guidelines. The samples were subjected to detection of SARS-CoV-2 by the high throughput machine that we have at our lab. So I'll tell you this: our lab, it's my lab at RMRC Bhubaneswar, was declared as a high throughput laboratory for the entire state, and we were involved in the testing of starting from this legislative assemblies, honorable president's visit, honorable prime minister's visit, Indian hockey team, then all honorable chief minister and entire ministerial staff, and during this Rath Yatras, our lab was involved in testing and declaring the result. So we did the test in this high throughput platform of Ross Cobas, which has high sensitivity and specificity than any other RT-PCR machine, conventional RT-PCR machine available, because it is fully automated, and which basically detects two genes, that is open reading frame 1, ORF1, and envelope gene of SARS-CoV-2. The tested sample was considered SARS-CoV-2 positive if both the genes were found positive. CT values were calculated inbuilt by the inbuilt software of the system. Next. The total for the positive samples, the saliva SARS-CoV-2 was RNA was isolated from the saliva using the QIAGEN kit, and we performed reverse transcripted complementary DNA using ABI kit. Then we amplified the RDRP gene, which is universal to all SARS-CoV-2, and spike gene, which is specific to the SARS-CoV-2 virus. And we did the using the standard published protocol. We did the PCR, and subsequently the gene sequencing was done in the ABI 3500. It is a Sanger sequencing capillary sequencer at our institute. So this was done to because we could test to further confirm that the saliva samples that was tested positive in Ross Cobas RT-PCR machine was really was from SARS-CoV-2. So we did a capillary sequencing of two specific region of this virus. And we did the sequencing. We matched it with the gene bank, NCBI gene bank. The descriptive statistical analysis was performed using the various statistical methods. Next. So here, among the positive samples, the CT values were similar between the two methods for detection of both the target genes. In the NPS, you can see the values of CT values for ORF1 range from 16.56 to 36.2, and And in the saliva, it ranged from 16.83 to 34.65. You can see it is almost same. And for E-gene, it was, for NPS, it was 16.57 to 40.13. And the same for saliva was 17.18 to 38.72. The mean CTs of the E-gene in saliva was found to be 29.12, which is almost similar to the NPS sample. The difference between the two clinical specimens was statistically significant, and the specificity was 100%. Specificity was the chances of detecting all negative as true negative, and sensitivity was chances of detecting all positive as true positive. The specificity was 100%, and the sensitivity was 91.37% for the use of saliva for detection of SARS-CoV-2 from saliva sample. Next. So this was the comparison and agreement of CT values in RT-PCR by Roche-Gobas 6800 for NPS and saliva. You can see it has almost matched for both E-gene and ORF. Next. So this is the phylogenetic pairwise comparison of the phylogenetic tree analysis, and bootstrap desampling revealed that both the sequences, you can see these are marked by red blocks. These have the RDRP gene has branched with all the human SARS-CoV-2 isolated from different parts of the world. You can see this above, it is USA, Egypt, USA, this India. So, and the figure B shows the spike gene, which has again matched with the SARS-CoV-2 isolated from human from USA, India, Egypt. So it has branched all this RDRP and spike gene from our sample has matched with all the human samples, which was isolated from various parts of the world. And in the different branch, you can see the SARS-CoV-2, which was isolated from different other source like bat and other vertebrates. Next. Salient findings from the study. Although NPS, this nasopharyngeal swab, is being used as a gold standard for detection of SARS-CoV-2 virus, sometimes the collection techniques become so stressful that it gives some uncomfortable complications like pain, sneezing, cough, or vomit to the sensitive patients. This can be sometimes fatal for the patients. In addition, the method is quite time-taking, which results into the crowding at specimen collection centers and subsequently putting the healthcare workers at subsequent risk of acquiring the infection during the sample collection. It was observed that 5 patients were positive for NPS but not for saliva, which may be due to the low viral load in the saliva, which could not be detected in the saliva by the Roche-Gobas 6800. The gene sequencing analysis and subsequent phylogenetic tree construction was also corroborated our automated RT-PCR data that it is the first report of SARS-CoV-2 isolates from saliva in India, and to the best of our knowledge. Overall, the NPS and saliva specimen demonstrated a high level of agreement among patients with a positive outcome in RT quantitative PCR. So this was the first study where we used an innovative technique, and this is not only confined to SARS-CoV-2. Why I am presenting it here? Because this use of saliva as a potential sample for diagnosis may not be confined to only your SARS-CoV-2. We can very well use it, standardize it, and use it for other influenza viruses, where throat swab or nasopharyngeal swab is the ideal sample for testing. Next. Outcome and policy implication. Our study demonstrated the reliability of saliva for detection of COVID-19. Saliva samples can be collected by patients themselves, leaving no complication, as the process is fully non-invasive. This alternate could be a great relief for all the frontline health workers engaged in the collection of nasopharyngeal samples. It could be a worthwhile opportunity for the government to reduce the cost of sample collection, especially when the number of samples being tested for exponentially increased over the few years of that this kind of pandemics. Next. Next. So again, if you remember during SARS-CoV-2 pandemic, there was another UN cry that how CT value was related to our viral load. So there was we used to get frequent calls when you give out the result. What is my CT value? So we got fed up telling people that it has nothing to do with viral load, or it has nothing to do with a clinical complication or clinical presentation. CT value has its own, it's what I'll tell you, its own implication. Viral load has its own implication, and clinical complication had its own implication. So these are completely independent parameters. So there was a scarcity of information on antibody response to SARS-CoV-2 infection. SARS-CoV-2 antibodies have been detected for a range of few years to 3 weeks after onset of symptoms, with median time reported as 6 days for detectable levels of immunoglobulins class G, that is IgG. The presence of SARS-CoV-2 IgG antibodies is thought to confer some degree of immunity, which is indicative of current or previous infections of SARS-CoV-2. However, there is uncertainty regarding the duration and extent of immunity conferred by the SARS-CoV-2 IgG antibody. The SARS-CoV-2 antibody responses remain poorly understood, and clinical utility of serological testing was still unclear. And I will tell, still it is unclear. The study was carried out in which a semi-quantitative SARS-CoV-2 IgG antibody estimation was done to understand how body's antibody responds to correlation to the sensitivity or severity of SARS-CoV-2 infection, CT values, gender, and age. Next. Here we enrolled 384 individuals, again from different hospitals in and around Bhubaneswar, to evaluate the SARS-CoV-2 IgG between 4 to 6 weeks after confirmed positive of SARS-CoV-2 by RT-PCR from the month of August to October 2020. The CT values, age, gender, and symptoms of the patients were correlated with the development of the antibodies. Patients who carried with any one of other symptoms such as fever, breathlessness, cough, fatigue, muscle pain, clogged nasal cavity, sore throat, diarrhea, loss of taste, loss of smell during the time of RT-PCR testing was considered symptomatic COVID-19 case. Confirmed COVID-19 cases were defined as those that tested positive for SARS-CoV-2 RNA using RT-PCR testing by combined nasopharyngeal and oropharyngeal swab testing by RT-PCR. Next. Semi-quantitative SARS-CoV-2 IgG testing was performed using Abbott I2000 platform, which uses chemiluminescent microparticle assay technology for detection of IgG antibodies against the nucleocapsid protein of SARS-CoV-2 from human samples. The cutoff for the antibody response was 1.4, above which the sample was considered positive. This is again a qualitative test, not a quantitative test. Next. Out of the 384 samples collected for SARS-CoV-2 RT-PCR positive samples, 80.2% of the samples were found to be positive for antibodies against SARS-CoV-2. You see here, out of 384, we got 80% only positive for some IgG, and the rest 20% did not develop any kind of IgG after the infection. The median time of sample collection was 34 days after confirmatory RT-PCR. So the median days after which we collected the sample was 34. Till that time, 20% of the sample, 20% of the cases did not develop any IgG antibody. The mean age of the IgG positive and negative individuals were 36.94 and 36.09 respectively. The IgG positivity was found highest in the age group of 60 years. No significant difference for antibody response was detected among different age group. The samples were collected predominantly from male, that is 86.9%, and female was only 13.1%. These males were having higher chances. However, the sample size was not significant enough to conclude it. But as we all know, getting samples and getting participants enrolled during COVID-19 pandemic was very difficult, because there was so much taboo among the people after recovery or during COVID-19. That why we are collecting sample, are they, means antibody positivity is again, are they positive? So we had to convince them. It took lot of time for us to enroll these cases and get their sample for blood samples. Because this is done with the blood sample. Next. So here you can see there's some bar graphs where you have shown the association between demographic characteristics and CT values with IgG antibody responses. A shows percentage of IgG results in various age groups above 60, 45 to 59, 30 to 44, and less than 30 years. Percentage of in the B, we have measured antibody development across the gender. In C, we have measured antibody development in symptomatic and asymptomatic cases. You can see antibody development was almost similar in symptomatic as well as asymptomatic cases. In asymptomatic cases, 81% developed antibody, and in symptomatic cases, 79.9% developed antibody. Coming to the CT values, there were significant difference in the CT value antibody development in the CT values, because in the CT values less than 20, there was significantly higher antibody development after the infection. Next. Summarizing the graphs, the mean CT value of the symptomatic and asymptomatic patients were 23.48 and 24.16. There was no statistical difference for IgG response between symptomatic and asymptomatic patients. The mean CT value of the IgG antibody positives was 23.34, and in IgG negative was 26.72. The percentage of IgG antibody positives increased with a decrease of CT value, which I was highlighting. Because, and which was statistically significant also. The lower CT value cases, after recovery, they had a higher percentage of IgG antibody positivity. The antibody titer values of positive individuals, mostly 71% presented between 1.4 to 6 index. Next. So this is a scatter graph where we have shown the antibody titers versus CT values. We can see the antibodies development has higher concentration in the CT values below 20. Next. Again, outcome and policy implications. In the study, the antibody response was found to be 80.2% among COVID-19 positive individuals, which has reported by some, as it was reported previously by other geographical countries. Antibody titer was found to be directly proportional to the lower CTs, means lower the CT values, higher the antibody titer. Higher viral load might lead to the development of stronger immune response in SARS-CoV-2 infected individual. IgG response was greater in males than females, but statistically insignificant. There was no statistical significant association between CT values and development of symptoms. We did not find lower the CT value or higher clinical complication, or higher CT value, lower clinical complications. We didn't find any such kind of cases. So CT value had no relation with clinical complications or clinical development. Next. So since MITS is an academic institute, we thought I'll just tell you a facility that ICMR has developed. It is ICMR Research Infrastructure Sharing Ecosystem. This is the portal where we have put all our high-end equipments, starting from PCR, RT-PCR, RNA extraction, DNA extractor, spectrophotometry, sequencer, everything. in this portal, which can be used by any educational or research institute. There is a very nominal cost. You can register here. You can raise an indent here. Then the concerned lab will approve and will give you a appointment. You can come on that day. Our technicians will be present here. We will give support for testing, and the result will also provide help in interpretation and analysis of result. Next is the online certificate course on One Health that we have developed, and it is the first of its kind from our country. As you all know, that One Health has gained enormous importance in present day, and this is taken up by the Ministry of Education, and it is available free of cost, provided by IIT Chennai. It is a SWAM platform, and it is a 3 months course. It is given free of cost, and we have roped in different experts from ICMR, DBT, ICAR, Nivedi, veterinary department, agriculture department, health department, and even from prestigious college like institutes like London School of Tropical Medicine and Hygiene, George Institute. Experts from there have provided lectures. You can enroll. You can see the present. We had this is the third phase of the course is currently running, and presently we have enrolled near about 8,000 participants all over the country, as well as from abroad. We have participants from USA, UK, Canada, Sri Lanka, Bangladesh, who have taken up the course. And again, it is a free of course. Even the faculties can take up. It is the credit. You can get a credit point of 3 from this. So thank you. This was my presentation. Now you can ask me any question. This is my small team, and this is the part of the team. Some people are absent here, so we have a team. We can. Some people from here are from your midst. Thank you. You can ask me any question.
Thank you, sir. Thank you so much for your insightful and relevant topics, sir. Actually, the name is very common, the COVID-19, but the research and the background, the things are very difficult, and you have explained that is very nicely, sir. Thank you so much. And the today the platform is open to all. Anybody can ask the question after raising their hand. So you are expecting the questions from after. Please raise your hand, then you can ask your question. Yes, Dr. Ruzaksha Panda, sir. Please ask if you have any question.
Good afternoon, sir. It was a very nice presentation. Can you hear me?
Yeah, I can hear you. Tell me.
So I have just one query, sir. In RT-PCR, sir, we can perform any small experiments. We have this facility here in our institute. Any small experiment we can plan so that we can tell the students about these things.
The question is not clear. You have an RT-PCR machine in your institute.
We have RT-PCR in our institute. I was telling, sir, if we can collaborate and do some work for the students with you, sir.
We are always open for collaboration. As I told you, we have many MSc dissertation students who are working in our institute from MITS, and your passed out students are also working in our lab, so it will not be a problem. Even our director, Madam Dr. Sangamitrapati, is very much open to collaboration, and she has over this last 8 years has supported various institutions for their development.
Okay, sir. Thank you, sir.
Thank you, sir. One question came through the message box from Dr. Mausumi Mishra, that how can academic institution collaborate with industry to accelerate the development of new diagnostic tools?
Madam, you can, if you have some prototype or something, you can approach the institution, you can approach ICMR. We can give a technical support to you, even if it is not in our domain. We can rope in experts from other institutes who can help you in the development of this further development of this prototype, because we give support to everything: development of your kit or diagnostic tools or machines, instruments, validation, because we have a good number of epidemiologists who are doing that sensitivity specificity testing. We have a department of health technology assessment which does the validation, cost effectiveness, feasibility of this what I'll tell, putting it in the health system programs of the government. So we can give you, we can support you, we can provide you technical support throughout the entire process. And even the ICMR has a MedTech Mitra platform which gives support to these startups or academic institutions to further refine or develop their product.
Thank you, sir.
Thank you, sir. Dr. Rasmi Ranjan Mishra, our HOD, has raised his hand. Sir, you can ask questions, sir. Rasmi, sir. Hello.
I think he has raised by mistake.
Some error is there, I think. Sir, actually, you have explained that in that this is just molecular diagnostic is
Hello.
now a yes, sir. Please ask.
Thanks to Badajay sir for your nice presentation. So, of course, it is the last day of faculty development program that we have conducted in our department, and so many eminent professors, they have given their talk. And as we know that COVID is a very hot topic and we all face a lot of problem due to coronavirus and all. My question is that, sir, we have taken Covaxin and Covaxin during that COVID period. In future, now it is required to, we have to be vaccinated or not? Our government is planning to give vaccine for future protection.
See, for government to give a further vaccine depends on generation of evidence.
Yes,
If
yes.
we have evidence that I'll ask you another question. Did you notice that post administration of vaccine, there
Yes.
were reduction of the clinical complication of the cases? Because once the third phase, the admission as well as death has drastically come down.
Yes,
This
yes,
was
sir.
the positive implication of vaccination.
Yeah.
Because vaccination has made our body ready to combat these viruses. So government may not see, for government, you can imagine the vaccination of this 140 crore population.
Yes.
It is a huge cost for the government, and that also
Yes, sir.
3 times giving vaccination,
Mm.
because they gave first dose, second dose, and precautionary dose. So giving
Yeah.
3 dose free of cost to the entire population was a huge financial burden to the government. So before deciding on giving another vaccine or a booster dose, it will need some evidence where it comes out that the previous vaccine is ineffective in further COVID infection.
Okay, sir.
If it gives
Thanks.
protection, if it brings down the clinical, see, COVID, when in the third phase we had slight mild fever, okay, cough, cold, and it gone. Like it was like an influenza fever. So
Yes.
government will not bother further until and unless there is a huge burden in cost to the government as well as hospital burden. Government will not bother.
Okay, thank you. Thank you, sir.
Thank you, sir. Sir, I want to ask one thing that, sir, you have explained that molecular diagnostic is now is a gold standard method because of the specificity and sensitivity, and the test report is early as compared to other conventional method. but still the doctors are rely on that conventional method instead of this molecular diagnostic. Is there any issue of the cost or awareness or any other issue?
Because doctors, clinicians, they send the patient to some facilities for testing. Molecular diagnostic is not available everywhere. A PCR, RT-PCR is not available everywhere until unless it is a hospital like institute like RMRC or ILS or AIMS or Apollo or Ambi. If a patient goes to a private clinic and asks and doctor writes there, you do a RT-PCR for this, that, so he will be searching where to do it. Or if he goes to any diagnostic like Thydocare, Lalpath and all that, they will be charging a huge amount. So basically, it depends on the doctor. Based on the patient's economic condition, he writes. And when the clinical symptoms is presenting to the doctor, he will write the diagnostic method to be followed. It may not be
Yes.
always. He will write PCR or RT-PCR you do, because you see a person in BPL, the below poverty line, he will not be able to afford a PCR test.
Yes.
for healthcare.
So the major thing is the cost, sir. Actually, cost of
Yes,
the kit is
Yes.
because nowadays a lot of companies are introduced the different type of multiplex PCR in the infectious diseases, but the cost is major issue, I think, sir. Okay, sir. Thank you, sir. Any other? Anybody wants to ask any question? Because this topic is very relevant to our FDU program.
Even if you don't have any questions, my email ID is available with your faculty. Dr. Rashmi Ranjan, I think Dr. Kaur also, Dr. Subrat also has my email ID. You can
Yes,
write to me anytime, and our institute is open to any kind of collaboration, any technical support. You can come down anytime. We'll be happy to support you.
Thank you,
Okay,
sir.
thank
Thank
you,
you
sir.
for
Thank you.
yes, to well, sir, director, sir. Can you conclude this session?
Yes, please. Yes, please.
Okay. So thank you so much. Thank you so much, sir, for the joining us in the last session of the FDB program. And this topic is very relevant and this common. The name is very common to all of us because the COVID-19 is the common name for all. And you have explained this topic excellently, sir. Thank you so much. And now I'm concluding this session, and I am requesting all the participants to continue to stay here in this link for the validity session. Stay tuned with us. We will come within 5 minutes for the validity session.
Right, sir. We can continue right now.
So,
Okay, sir.
May I
I-
request Bhattacharya sir to stay for 5 minutes, please?
Yes, sir. Sir, please stay us with for 5 minutes. Then you can.
Dr. Kaura, you can start it right now. All are joined right now, right? You can start.
Okay,
You
sir.
can start.
Okay, sir. Okay, thank you, sir. So, good afternoon, everyone, once again. Honorable Chief Executive, sir, Engineer Shriram Panda, Distinguished Vice Chairman, sir, Mr. Bishwajit Panda, respected Director, sir, Dr. J.K. Panda, esteemed Speaker, Dr. Devagata Bhattacharya, sir, respected HOD and faculty member and dear participants. It is my privilege to welcome you all to the validity session of this 5-day faculty development program on next generation molecular diagnostics for pathogen and cancer detection. As the convener of this program, I am both delighted and proud to stand before you, reflecting on the remarkable journey we have had over the past few days. Now, I would like to request our respected Director of Mid School of Biotechnology, Dr. J.K. Panda, sir, to welcome the virtual gathering. Sir, over to you, sir.
Yeah, thank you, Dr. Kar. And good evening, all. It gives me immense pleasure to be in this elite forum as we conclude this engaging and uh, insightful FDP on next generation molecular diagnostics of pathogens and cancer detection. Over the past 4 sessions, we have had the privilege of delving into groundbreaking advancements in pathogen detection, cancer biology, exploring technologies like RT-PCR, next generation sequencing, diagnostics, and liquid biopsies. The knowledge and perspectives gained from these sessions have undoubtedly enriched our understanding and will enhance our approach to both research and clinical applications. At the outset, I would like to extend my heartfelt gratitude to our Chief Executive for his unwavering dedication and visionary leadership, which continues to drive innovations at our MITS groups. I would also like to express my sincere thanks to our Vice Chairman for his invaluable guidance and encouragement in promoting academic excellence. A special thanks to my colleague, the convener of FDP, Dr. Subrat Kumar Kar, whose proactive coordination steered us toward completion of this event. My heartfelt felt appreciation goes to the entire resource persons, Dr. Sanatan Maji sir, Dr. Priyaranjan Dutta, Dr. Manjusa Dixit, Dr. Rahul Modak, and of course, today's resource person, who is none other than Dr. Devdatta Bhattacharya sir. The exchange of ideas and expertise among such a distinguished group of professionals has been invaluable. Throughout this program, we aim to bridge the gap between research and clinical application, ensuring that we as educators and researchers remain at the forefront of molecular diagnostics. These sessions have been provided us with the deep insights, opening new avenues for impactful research and better healthcare outcomes. As we conclude, I urge each of you to take the knowledge and inspiration gained here and apply them to your respective fields. Once again, thank you all for your active engagement and valuable contributions. Let us carry forward the spirit of learning and discovery as we work toward a healthier and more informed future. Our esteemed Chief Executive is in our group. I hand over to Dr. Kar for next proceedings.
Thank you so much, sir. Thank you for your words. Now, may I request our Honorable Chief Executive, sir, MITS Group, Dr. Engineer Shriram Panda, sir, to share the keynote. Over to you, sir.
Thank you, all of you. I think this is very good, which the way we have done it. I think I should congratulate our director, sir, Professor G.K. Panda, sir, and convener, Dr. Subrat Kumar Kar, sir. And today's session by Dr. Devdatta Bhattacharya, sir, has been extremely good. What I can listen from sir's talk. So, and also the last 4 other speakers on 25th by Dr. Sanatan Maji sir, 26th by Priyaranjan Dutta sir, 27th by Dr. Manjusa Dixit madam, 28th by Dr. Rahul Modak. So all these sessions are based on some important discussions which needed to take forward. I just want to highlight we are at the cusp where our country is progressing towards an innovation-led country. Because from doing basic sciences, we are slowly going towards doing advanced sciences, doing advanced research. So India has been the land of innovators. India has been the land of inquiry speakers. So I think my request would be, if this is the right time where I think we should go forward and see that we take care of all these discussions, all these talks, and we properly utilize this to take proper sessions, and we inspire our teachers, we inspire our students, we inspire all the people who are part of the faculty development program to see that this regularly happens and we keep on brushing our knowledge and take things forward. I like to thank everybody of the team for supporting this particular initiative and also going forward. Thank you very much, sir. Good work, all of you. Thank you.
Thank you so much, sir. Thank you for your words. And now, uh,
Dr. Kaur, can we get some feedback from few participants, one or two?
Wanda sir, if you don't mind, can I leave because I have some
Please,
other thing to join.
please, sir, please take care, sir.
Thank you, everyone. Thank you. Thanks to you and the entire the organizing committee, the chairman, as well as all the faculties who have given lecture earlier to me and all the participants. Thank you for joining, and we are RMRC. We are here to support you at any time. Any help, we are here to help you. Thank you.
Thank you. Thank you very much. Subra sir, just a few words from any two participants. Dr. Chinmay Kumar, could you please share your views? Just unmute yourself, and this lobby is open for all. Please share your views. Any remarks, any suggestions, views?
yes, we are expecting. Yes, sir. Thank you. Please, sir. Any faculty member?
Okay,
So,
Dr. Kar, it would be better if we wind it up, or we can move to the last stage. Of course, we have given a small suggestion, or what is called a line of comment to everyone, that all need to post their photographs, along with they need to check out whether their credentials are okay or not. We've given a PDF. All are requested, and a number of have already given, posted their photographs, along with they put their credentials. Rest members are requested to do it soon, so that we can move to make the certificates at the earliest. Dr. Kar, over to you to conclude the FDP.
okay, sir. Thank you, sir. Okay, I wish to express my deepest appreciation to all of you, our esteemed participants, for your enthusiasm, engagement, and willingness to learn. Your active participation and the discussion we have had over the past week have been inspiring. It is our commitment to growth and excellence that has made this program such a success. As we reach the conclusion of this PDF, I encourage each one of you to take the knowledge and skill we have acquired here and apply them to our teaching, research, and practice. The future of molecular diagnostic is full of promise, and as educator and researcher, we have the power to be at the forefront of these revolutions. In closing, I would like to thank the organization committee, our executive committee, and the administrative support for their unwavering commitment and effort in making this program a success. I also express my gratitude to our esteemed speakers of sharing their expertise and contribute to the success of this program. So we conclude what Sir already told you, that I would like to inform you that the certificates will be shared to your respective email ID before Sir what Sir told you that you have to send your passport size photograph and the feedback to fill the feedback form, and we'll share your certificate in your respective email ID. Thank you once again for your participation. Let us continue to strive for excellence in research, teaching, and application of next generation molecular diagnostics for the betterment of public health. I wish you all the very best in your future endeavors, and I look forward to our continued collaboration. Thank you so much. Thank you all for the participation for the 5 days in the 5 days uh, faculty development program. And thank you again for your participation. Thank you.
Thank you, Biotechnology Department led by Dr. R.R. Misra. Thank you again. And thank you all the participants.
Now I conclude this session, and I'll leave this link.